I'm Dr. Hackie Reitman. Welcome to another episode of Exploring Different Brains. And today I'm excited because we're going to learn from one of the world's authorities on ADHD, which I got some of that going on too. And Mark Wollreich is nice enough to join us. He's written the books. He's invented the categorization. We're going to learn all about it. Mark, welcome to Exploring Different Brains.
Thank you for having me.
How did you get involved in all of these different brains kind of things?
When I was in medical school, first I got involved in pediatrics because that was the only rotation I really liked. It had the nicest people in addition to the children. And then I got involved with one of the faculty, Ted DeBono, who was interested in children with intellectual disability as well as children with what we called at that time minimal brain dysfunction, which is now ADHD. It was also when there was a big expose about the institutions for intellectually, what was then called mental retardation, called Christmas in Purgatory. I don't know if you remember the book. It was one where they took pictures and went through one of the large institutions in Massachusetts and showed how horrible the care was. And I got a similar personal experience because I was working with a geneticist who was getting blood samples from the Rome State School, which was a New York institution for intellectual disabilities at that time. And that got me interested in that. And Ted got me interested in the minimal brain dysfunction. And I continued to have interest on that during my residency, and then did a fellowship because that was before there was a subspecialty in developmental and behavioral pediatrics. So it was called on the handicapped child at the time, and it's always fascinated me over the years. Part in with a lot of consistencies that really go back to the time when I got started that are still present with it. But it also got me involved. Coming from being the son of a Holocaust survivor, I've been very sensitive to how minorities and how individuals with disability are treated by society, and that it's very important in terms of the services that you can have.
Well, I hope that we as humanity have learned from the Holocaust. Sometimes I wonder, and I certainly hope we have.
Yeah, I wonder too, given the current time.
Yeah. Tell us about the Vanderbilt ADHD Diagnostic Rating Scale.
Well, to give you some background before getting to the scale, back in the 70s and early 80s, there was what's now in terms of the mental diagnostic categorization, there was the DSM, but it was not widely used outside of psychiatry. So pediatricians who have had an interest in ADHD didn't have necessarily the same criteria. And I really felt that to be able to communicate and coordinate services between the different providers of services for individuals with ADHD, it really should have more defined, unified diagnostic criteria process. So I developed the ADHD scale, and it wasn't the first. There were other scales that similarly that were developed around that time, but that includes all the criteria from the DSM system, and could be used more easily in primary care settings as well. And I initially developed it for research I was doing about how primary care clinicians were dealing with kids with ADHD, but then went on to make it so that it's available through the American Academy of Pediatrics, but also that it's in the public domain, so there's no cost for the scale, to now where the DSM criteria are pretty universally accepted as the criteria for making the diagnosis.
Well, that's kind of a segue into your involvement in the Siperstein-Wohlraisch adjective checklist.
Well, that actually predates doing the Vanderbilt rating scale. Gary Siperstein and I were interested, particularly in the attitudes of clinicians in dealing with kids with intellectual disability, and getting a sense that most clinicians don't really know the capabilities of individuals with disability and what they're likely to be able to do or not do. So Gary had developed, for other reasons, using what's called the adjective checklist. And so we essentially took different items from very basic, like eats from a spoon, drinks from a cup, up to uses a telephone, manages, checking a checkbook, and asked clinicians what they thought someone, and we would either have a case or a level of intellectual ability for them to say what they thought that those individuals would be able to do by adulthood. We surmised, which was what we found, is that they tend to be more pessimistic about the conditions, and the more severe you describe the disability, the more pessimistic they are in the cases. And so we did also showed that it affects then decisions about treatment involved, that if they're very pessimistic about how well they could do, they tend to be not as open to treatment. So we used a combination of cases. One of the examples would be children with spina bifida, because for a while I was for 14 years, ran the spina bifida program at the University of Iowa, that if the case was severe, they were a lot less eager to provide aggressive treatment for the kids. So we would give a case that we would describe as more severe, and then ask what they thought those individuals would likely be able to do when they were adults, and if there were a mild case, what they would be able to do.
Wow, you bring back memories of part of my orthopedic rotations at Boston University with the Shriners Hospital for Crippled Children out in Springfield, Mass. And, there was a wide range of those patients. And there's a lot to be said about names,
Yeah.
and the effect they have on people. What would you say that most people don't understand about the way that ADHD and similar differences are diagnosed?
The diagnosis for ADHD is really based on observed behaviors, but it's observed behaviors not like you're taking an intelligence test where you see which done. It's behaviors you observe within the setting, within the family, with how they're doing in school. And so it's more complex, but it's basically when behaviors, particularly around difficulties being able to pay attention and to think through things, about being impulsive and overactive. And it's been interesting that the behaviors for what was called minimal brain dysfunction and then now ADHD have been constant over the years. If you go back to around the turn of the century, a surgeon in London described the condition very much as it occurs today. And there was also a German primary care physician in the 1850s who wrote a book that has Harry who looks in the air and Fidgety Phil, both who come to no good as part of it as children's books at the time. So the elements of inattention, hyperactivity, and impulsivity have really been constant now over 40, 50 years.
My daughter Rebecca was doing some tutoring in a school, and she would take the kids in some of the special ed classes who were really disrupting the class, take them separately and try to tune in on what their deal was. And I remember once this kid who was in math class kept getting thrown out because he was fidgety and wouldn't do this and that and was disrupting, and kept getting up to walk around and all. And she took him in a separate room, and he was really kind of nasty and acting out. And she said, would you like to pace around while we do this work? And he said, you'll let me pace? And she said, yeah, as long as you do the work. So he paced around. It was a pleasure. He just had to be pacing because his brain was different. And that's just an example of, I guess, considerations. I'm not saying everybody should do something like that, but like you're saying, you look at the individual's brain because every brain is different. And it's not like, well, he's got ADHD, therefore XYZ. It's what is that individual doing?
But you do have to function within a society.
Yes.
So
yes.
You really have to have some skills that enable you to do that.
Yep. So you have to learn the tools that'll let you get along with society. Right. And likewise, society, for its own benefit, has to learn how to make some accommodations. Talk about the importance of having a team approach to the individual with ADHD.
Well, there are multiple challenges for kids with ADHD. So you're talking about certainly school as a big one in terms of it. And there are large number of the kids with ADHD will also have learning problems as part of it, and language problems. And there's a high co-occurrence of anxiety disorders or depression as part of it. They frequently have motor challenges in terms of, again, coordination of what they're working with. So you're dealing with a number of different people that can be professionals that can be of help for them, from the clinicians who treat because the medications are effective in helping kids to concentrate, particularly teaching parents in behavior management that psychologists do, particularly for the younger kids, is an important factor. Dealing with the educational problems they deal with. One of the things for me that enticed me when I was in my last year of medical school was Ted DeBono, who was one of my mentors, had set up a clinic in combination between the medical school and Syracuse University, and it included speech clinicians and psychologists and educators as part of it. And it was fascinating seeing how they look at children differently than the physicians look at, and bringing them together really comes up with a much more effective way of trying to address the needs.
Tell us about your involvement with REACH.
Okay, and you're going to be interviewing Peter Jensen in the future. Peter Jensen's a child psychiatrist, had worked in NIMH, National Institute of Mental Health, for a number of years, particularly for a lot of the large studies that were done that gives us the evidence, and really felt that what was needed was is to be able to train primary care clinicians to better manage mental illness in their patients, because there are only about 7,000 child psychiatrists in the country. And if you figure it out based on the number of children, that means that have challenges, that comes out to they would get about 36 minutes a year per patient, that it really needed additional coverage, and that there's poor communication that goes on between the people. So I got involved with him in some of the early development of the program, and became a more active teacher over about the last 8 years. What's been fascinating for me is it uses a very much of an adult learning method. In my earlier studies, I was trying to look at how we could improve training for pediatricians, and found that lecturing really doesn't do the trick for them. We tried doing what the pharmaceutical companies do, of having someone come to the office of it, but that works okay if all you want to do is get them to realize the name of a particular drug that they would like to promote. It doesn't really help them with the skills they need to provide the services that they do. So the REACH program developed what's basically a 2.5-day program that is very interactive. It has role plays, it has table exercises as part of it. And then it's followed up, which is an important element of it, with 6 months of twice a month case conference calls, where those who participate in the course then get a chance to present a case, and there's discussion about the case. But I've sort of been knocking my head against the wall now for years, trying to convince pediatrics that the training of pediatric residents has to have more training in development and behavior, which it still doesn't. The requirements in most residencies is only 1 month out of 3 years. And it's sort of ironic because over half of the kids that the physicians are going to be taking care of have some mental illness as part of what they're dealing with. ADHD is the most common, and that's what they do. But they're certainly providing also the primary care for kids with autism. They're providing it for kids who have anxiety or depression as part of it, and they get very little training in that. The residency still is primarily focused on hospitalized patients. And in reality, if they're in primary care, they may not have any hospitalized patients, because now there's a subspecialty of hospital physicians taking care of it. So they go into practice with over half of their kids having chronic illness and developmental and behavioral problems without the skills to really treat it well. And the REACH program does help in terms of the behavioral and mental illness conditions.
I gave probably the only lecture they ever had at the American Academy of Orthopedic Surgeons on neurodiversity. And the tack I took with my fellow orthopedic surgeons was, it's not their fault that in medical school and orthopedic residency you get zero training in this stuff. But I said, look, you're already treating X% of your patients are on the spectrum or have different things. And I said, let's just take autism. If you start to look at everybody a little differently, I said, remember that patient who it took you 45 minutes just getting the fiberglass cast off and the kid was screaming and you thought it was just a poorly brought up kid? And that's because they're hypersensitive to vibration. You could have saved yourself 45 minutes of your office time if you used plaster and had them start to soak it off at home, okay? But you can't know that. You got no training in it. But if you start to look at it like that, then you can make those little things. And I think that got their ear only in the sense that it was something tangible that could be taught and would help them in the office, and also converts to a better bottom line in their practice too. Because let's face it, you spend 45 minutes on a patient that could have taken you 15. It's a big difference. So, and I know that our friends at the AADMD in the dental area getting the dental students, and they finally got the dental board to change the rules that you have to get that much more training of disabled individuals.
Well, I've been pushing for 30 some odd years in terms of pediatric training. Part of the problem is how training is funded. Residencies are funded through government funds to a great extent that come to the hospitals. And so what they get trained on is still primarily hospital care and the severe conditions. They spend a number of months in the neonatal intensive care unit, and when they get out in practice, they're not likely to be using any of that on their own, because that's become very much of a specialty center. But it's been very frustrating. We really worked. I was very much involved in helping to develop the subspecialty of developmental and behavioral pediatrics. And we have pushed to try to get that to be more of the residency. And I just learned in the program that I retired from that they're actually going back the other way. Even that month is divided up, so it's really not as effective training. And it's not surprising they get out and they don't know how to handle the cases that we teach in the REACH Institute, or how to best deal with kids with autism or and other conditions.
I used to have these discussions with one of my old classmates, was the head of the National Institute of Mental Health for a while, Tom Insel. Mm-hmm. And, it's tough to turn around the elephant, It's tough to get it going, but there's got to be a way to do it. But I guess we're not going to figure it out today.
Yeah, we're not figuring it out today. The REACH program has now had training of over 5,000 primary care physicians. So it is making a dent in the program in how well they're able to handle cases. And so that's been encouraging. But until we also get eliminate the separation of mental health from physical health, so that it's all one person that we're dealing with, there is not a good way that conditions are handled or coordinated between it. And when you're limited to 15, 20-minute visits on patients, those patients that need a lot more help really have difficulties.
Well, I think the odds have improved paradoxically for getting the education out thanks to COVID with the rise of virtual learning like we're doing now. And I think that makes it much more possible in a very limited fashion to educate the already, out there practicing bunch.
Yeah, that's what the REACH program right now has been all virtual. And actually they've been able to maintain, which we had some concern over what all of the things they were doing with table exercises, role plays, on doing it virtually, and it still has worked. And at least the feedback we get has been very successful. But it's also you still need more time. 2 or 3 days or a virtual call doesn't replace what would be a much better training program for physicians, and particularly during their residency.
Sure. Mark, is there anything we haven't covered today that you would like to cover?
Well, I think we've talked about it, but I have to really emphasize the issue of getting clinicians to communicate with each other on patients and across disciplines. What we talk a lot with when we have the case conference calls is have you spoken to the child's therapist, their counselor as part of it, and how well we don't have the structure in place to get communication between clinicians that they need to. We hear continually, particularly when you have the walls up between what is mental health and what is physical health, that there isn't the communication and coordination that's really needed as part of it. And it would take too long to talk about just how corporate the whole healthcare system has become over the years. All healthcare now is through large health corporations, be they medical schools or private things, and that has some benefits, but it's also had a lot of drawbacks.
Well, we're going to have you back another time to explore all that, because while it's not just in what we're talking about, as you said, it's affecting everything. And I could not have practiced orthopedic surgery the way I did today. Wouldn't be allowed to do it. The structure wouldn't put up with it. Mm-hmm. And but that's a subject for another day.
And you can't manage kids with ADHD solely by 15-minute visits, as pediatricians are required to do in most practices.
Well, Dr. Mark Walraish, it's been such a pleasure to have you. I learned so much, and I'm sure our audience did. How can they learn more about you?
They can probably Google my name and see it. I've been active in the American Academy of Pediatrics over the years, so there's that. And also through the Society for Developmental and Behavioral Pediatrics that that is with subspecialty. That's a relatively new subspecialty that I was involved with in forming. Are probably the most. They can look. I spent the last 20 years at the University of Oklahoma, and they can certainly look at that. One of the things I think that you may have an interest is I developed a service navigation program with county coordinators and involving primarily families in Oklahoma that is still active and continuing to grow. It's not statewide yet, but it's in about 13 counties.
So that can serve as a template for other states as well.
Yes.
That's great. All right, Mark, we hope you'll come back again soon. Keep up the great work you're doing. And thanks for all you're doing, not just for ADHD, but for everything. Thank you so much.
Thank you. I've enjoyed it.
Exploring Different Brains is a production of Different Brains. Visit us at differentbrains.org.